I'm delighted that we're going to move on to our panel discussion. And I know you've been sending in your questions, so I need to put my glasses on now so I can see them better. Please keep them coming. And I'd like to welcome back our speakers. That's Kevin, Andrew, and Sharon. And I want to introduce Anne Lawlor, who is the founding member and chairperson of 22Q11 Ireland Support Group. And Anne joins the panel to share her lived experiences from the public and patient perspective. Anne's daughter, Anya, who I think Anne is now 38, was diagnosed with 22q-DS at 15 years of age. And since then, Anne's been championed, I suppose, or being a champion for better coordination of care for those affected by 22q and other complex care conditions. And Anne is very well known here in Ireland and indeed overseas as a rare disease advocate and a driver of change. And in 2017, she was the recipient of the Global Genes Rare Champion of Hope Award. So Anne, thank you very much for joining us today. And I think everybody else on the chat on the panel has said a few words already. So before we turn our attention to the questions, would you like to share your thoughts with us on the importance of research and just give us your perspective?
Thank you, Mairead, and good morning, everyone. It's such a delight to be part of this conversation, and thank you for the fantastic presentations. I think Sharon has adequately described our journey in a lot of ways with her words. I would say, you know, as a parent, I don't have any medical or clinical background or research background until this this rare condition came to visit us and our family. So we're a very, very small group. But when Anya was diagnosed, she had a kind of a host of disparate symptoms, minor disparate symptoms in the grand scheme of things, but nobody was dot joining those symptoms. And the consultants and the doctors and everyone else who saw her did not consult with each other. Her condition meant that it was so wonderful this morning to hear about the psychosocial determinants and all of that, because I can't remember who it was there. I think was it Jennifer who spoke about loneliness and social connections and lack of confidence. This was my child's life, all of that. And I didn't know why before her diagnosis, and after her diagnosis, it wasn't much better. So, and it's a very, very isolating place to be as a parent and for her as she was growing. So she was well into her 20s when I got to an international conference and was quite blown away to learn that there was upwards of 3,000 research papers on this condition. But none of it had filtered down and none of it had practical implications for families. So, you know, the rare disease, I suppose one of the issues with this, Mairead, is the name rare, because, you know, we all conjure up, when we hear a language or a word, we conjure up images in our head. And certainly having lived with Anya for 15 years and then afterwards, I said, well, maybe she has a rare condition, but these symptoms are really, really common. But nobody was looking at that. And individually, rare conditions are rare, but collectively, they are quite a significant number. So we started off very slowly. Like I say, I knew nothing about research. Now I am the most avid research advocate you could come across, because I had to get the evidence to do what we've done. And before we started, there was nothing here. And you would invariably go to your school, your doctor, your consultant, your hospital, and blank look. What is this thing this person is talking about? 22q, never heard of it. So I suppose what really, and we have accomplished so much, Mairead. We now have a fabulous pediatric clinician, a fabulous adult clinician, and going into post on the 15th of this month, I'm so proud, is a care coordinator. So how did we achieve this as a very small group? Through research. Because we were not funded, but we fundraise, and we got a lot of our money was spent on employing an independent mental health researcher. So that's how we got to where we are today. So we're coming at this from, I suppose, a public and PPI, public and patient involvement perspective, rather than from a researcher perspective or a clinical perspective, although we're working together with them. And it's been a hard but fantastic journey. And we have a small population, as I said, 180 families at the moment, but really I should have in the region of 2,500. So one of my research questions would be, how do we find them? How do we find them and bring them in and develop this care pathway that we've been doing? So I think that's enough for me at the moment. Thank you.
Thanks very much.
And I would say one more thing, Mairead. Kevin and Andrew, that was fantastic. I was all the time thinking about Dr. Austin O'Carroll here in Dublin, who made sure that our homeless population got COVID vaccines. He would have been so enthralled with your and nodding his head. Yes. Thanks, Mairead.
Thanks very much, Anne. And he's done great work. And you raised a very important question there, I think, and one we're grappling with as well, which is around implementation of research findings. Because actually there is an argument that loads of, we've plenty of research. That's not the problem at all. What we have a problem is an implementation gap when we don't implement it. And I suppose related to that, when I was listening to Kevin and Andrew, was the whole question of political will. And you raised the question of, what's going to happen after COVID, and will it all just go back to normal? Because it was incredible actually what we were all able to achieve with COVID, or what everybody achieved, when the will was there. So I don't know, are they related? Implementation, the whole question of implementation, that implementation gap, and how we actually, I suppose harness that will or get that political will to make changes. Kevin or Andrew, do you want to comment on that implementation gap?
Sure, I'll lead off, and Andrew will tell you the truth. Anne, thank you first of all for sharing your journey, and it makes me mindful of the Canadian Institute for Health Research patient-oriented research agenda. And I think as health researchers, one of the most important things we can do, particularly for those in the political realm of decision making, is true partnership with consumers. That when we go and advocate, when Dr. O'Driscoll goes and advocates for more research funding, well, what else would you expect her to do? That's her job, to advocate for more research funding. But when researchers and research funders and patients and their advocates get together, there is a political will around implementation that is very, very different, fundamentally different. And that is not to in any way diminish the more traditional basic science level of research, but to augment that and turn it into a social agenda. Mairead, this is a little bit of a inopportune comment for this time of the morning for us, but I think back to some work we've done under the leadership of our colleague, Dr. Alan Hudson, who is a former CEO at University Health Network. And Dr. Hudson took on the wait time strategy and went across the province and had a lot of money to invest. About $2 billion got invested on wait times. And as we looked at what worked and what didn't, there was no shortage of research. There was no lack of evidence around what to do and how to do it and why to do it. But there was a profound malalignment of incentives, a profound malalignment of transparency. And maybe the crassest answer to your implementation question is, when we boiled it all down, it was about data, money or investment, and sadly, embarrassment that really moved the needle, because health providers and social service providers are very competitive, data-driven people. And when we got data in front of them that said, you know what, you're not doing so well, they didn't like it. Well, so if you had one data set, and I told you today, Mairead, congratulations, you're in the top decile of performance based on your research. No one ever said to me, oh, gee, I think the data set might be flawed. But when you use the very same data set to say you're in the bottom decile of performance, the initial starting position is usually the data set is deeply flawed. And in reality, the data is no more flawed when we look at what we do well than what we do poorly. So as we go back and really say, who amongst us is proud to be in the lower decile? And as standard deviations get narrower, even at the 90th percentile, there is a lower decile. our goal is having that standard deviation so close to the shifted mean that everyone is getting that standard of research-informed care at a very high level. So, you know what, again, simplistic, but data, money, and embarrassment is what drives implementation.
Very good. Andrew, do you want to add anything to that?
Really hard to follow that. That's the truth, I guess, as Kevin was mentioning. I mean, again, I just to start with my gratitude to Anne and for all your leadership, and really just in terms of the movement that's here around the real importance of patient partnerships, no longer just engagement, and really helping drive and setting the agenda with researchers and the healthcare system, as Kevin has mentioned. And I think that really the steps that we've been taking at UHN to try to really help advance that, many other hospitals in Canada are doing as well. So, you know, my gratitude for that. I mean, I think it's really, you know, when I think about the implementation piece, and Dr. Driscoll, I might just go back to thinking about your point about what could be done in COVID, because I think Kevin has laid out probably the most pragmatic and important view to think about the three elements potentially for success on implementation, especially with practitioners. I think it's a really, really important sort of triad there. You know, I do think from a societal piece, I think, you know, to speak a little bit around sort of housing and social policy, to give a view just a little bit outside or sort of up from the healthcare system, you know, it's amazing what we mobilized so quickly when, you know, showed the photo of the gentleman in a room and having his own bed and bathroom. That person was denied that for decades. And all of a sudden with COVID, by April, I think it was actually by the end of March of 2020, we were able to provide that. Society was able to provide that. And I think it again goes back actually to some of the Lalonde report. I only go back because I find it one of the most humbling exercises as a person in health policy to reread what scholars and policymakers and communities were writing about in 74 is really, I think, about the last line, Dr. Driscoll, and in the Lalonde report, and saying that we have a decision now, each level, you know, both at the local level, in terms of every level of government, and as society writ large, about how we're going to share health. And, you know, I think that if we can't come through this in a global pandemic to understand that and make those decisions and continue with that political will, it gets hard to see how else that can happen. But I think the pieces and points that Kevin made are entirely right about, you know, the design and funding and alignment of incentives. Again, I don't think it's people have been wanting to do the wrong thing or bad thing in healthcare. It's just, again, we go back to thinking about system design and also be thinking about how we're designing our social policy systems. We're paying lots, you know, a significant amount of money for, I would argue, an anachronistic system with shelters. And if, you know, same way that a shelter should not be a solution for the housing crisis as sort of food banks are for food insecurity, if we can better understand that and be able to ensure that we're implementing more effective, more humane solutions coming through a pandemic, I think this is really the opportunity. And I think, again, I'm really just appreciative of everyone in the room and everyone who's been advocating and doing this work through the last 18 to 20 months. And I see Kevin is, I think, putting his hand up, so I'll make sure I pass it back.
No, very quickly, Mairead, I think the example Andrew has given, COVID did open some doors. So we would never, to Andrew's example of standing up a homeless hotel, we would have been in discussions with lawyers and government officials till beyond my retirement date, I'm sure, if it hadn't been for COVID. There were all kinds of risks. There were all kinds of challenges. There were all kinds of rules to break. And we did it, right? We did it by collaboration. And again, I think when the impetus is there and people can come together, that data, money, and embarrassment challenge should maybe be framed around, so how could we do that during COVID, but we can't do it now, or we can't do it when COVID is accommodated in a safer way? And I think we really want to be very careful not to slip back into our bureaucratic decision-making silos, as opposed to saying, you know, we actually did things during this pandemic in hours or days that previously took months or, God forbid, years. And what was it about risk tolerance, and how do we get all of the partners comfortable with that? I think the other piece to Anne's participation here today was having people who were focused and experiencing life with this disease, these illnesses and or their risks, and their family members. So it isn't just the self-interested in the provider and research community, but the decision makers and funders really hearing from people on the front line and a coalition of the willing, right? So politics is all about, in my view, getting enough voices to sing the same song that our political colleagues can't escape it, that they actually say, wow, when this many groups of people who usually can't agree on the color of the sky come together and are in full agreement, do we have a choice but to move forward?
Thanks. Anne, would you want to come in there?
Yes, thank you, Kevin. That is so important. I think one of my personal things was, when you have lived experience of something, you do gain an expertise. And then on the other side, you have medical and clinical expertise. And I've always said, if we could only marry the two of them, and I think that's what we have done. And that's when the magic happens. But you're talking about COVID there. I'm struck by the amount of parents that I've spoken to over the last year and a half. Parents who have children with disabilities, with genetic conditions, with rare conditions, some of them not so rare. And they all said, our lives have not changed that much because of COVID, because they're already living in that isolation and loneliness and social deprivation, So it's so important. And I think, and it's even in the language you are using and Andrew is using, it's in the we, And I've been doing a little bit of reading around design-led frameworks for engaged research. And it's really interesting to me because it's defined as the joint working of people who are not in the same organization to produce goods or services. So it is about hearing about all of our various expertises and recognizing that we all have that expertise. And I think in that, you see, there we have equity, when you can recognize the expertise and draw on everybody's expertise. For me, I think that's, personally, I would say that's what has happened with us,
Thanks, Anne. And I just want to bring Sharon in there, actually, because the whole question around, it's a big issue here at the moment, and I'm sure it is everywhere, around knowledge brokering, as they call it, between the policymakers and the research community and indeed other groups and patient groups and so on. So, what's the approach you take to that, Sharon, over there in the NIHR? In other words, trying to, where policymakers really often complain that the research that is done isn't useful to them, or it isn't, it's not what they want. And meanwhile, the researchers are going, well, the policymakers don't understand the world we're in. It just seems to be a little bit of a sort of a mismatch there. How do you recommend we go about sort of building that particular bridge?
Well, I can tell you what we do in our particular research programme, in that we're talking about implementation a few moments ago. And when we are commissioning research, as I mentioned in my presentation, we're always thinking about who's going to be using what we generate and who's it going to be of interest to. And a lot of our research is going to feed into policymakers and commissioners of services. But that's why the voice of public and patient involvement, PPI, is so central. And that's not just when we sort of identify topics I've already talked about, but in terms of where we bring people together. Say, for example, we have decision-making committees. They will have all those groups on them, including PPI involvement. So any topics we take forward through commissioning will have sort of that buy-in, that all different groups of people will support the topic, and that then feeds through. So, for example, when we make funding decisions, we will have committees that have PPI involvement, and research applicants will be advised that we'll be expecting to see PPI presence on sort of in co-applications, but we'll also be expecting them to be developing their research with members of the public and patients. So that's what's referred to as co-production. So that's how we try and make sure that everybody's voice is part of the discussion from the beginning right through the sort of research journey.
And you mentioned there as well, that's interesting, is that I was picking up on something you said, Anne, there about just the way for parents of people with disabilities and so on, life hasn't changed that much. I was just thinking, we've been trying to do this in the HRB now for a couple of years, which is to get patients, carers involved in research, and it's always a tricky one. What are the key levers here, do you think, for getting people involved in research? And of course, people are tired as well a lot of the time, aren't they? There's a huge amount of energy required for all of this?
Mairead, you know, the amount of research fatigue that I personally have gone through. I think there's a fabulous PPI effort coming from UCD at the moment on rare diseases, and I think, you know, it energizes me personally when I know for a fact that a project is going to yield benefits. It's going to have an impact. And that's when I get re-energized because I do get quite tired. And the other interesting thing is that, you know, in our whole journey, no one ever asked any of us, any of our families, what matters to you? I think that's a really important question, because when you're asked that, you know, you go way beyond medical needs. You go into those psychosocial areas that the families who, as I describe it, who live back at the ranch are experiencing on a daily basis. And if they get even a whiff of, oh, that might change some of that, then they become interested, you know. So we built our own research questions and our own topics on what matters to us. And that has proved really, really successful. Kevin wants to say something.
Yeah, and that speaks to, to Sharon's point, I think, about you know, co-design and being involved at that very early stage, even when you're
very
setting
early
research questions. So yeah, sorry, it was Kevin, were you going to come into that?
Yeah, I was going to add Anne's comment and a bit of our experience. You know, the knowledge translation language has permeated us for a long time, but until we really moved to a model where consumers or their families were embedded in all of our process at University Health Network, we have about 150 patient partners. And they're involved in everything. They're involved in hiring, they're involved in research questions. When we're using our funds, they're on the research panel. And the result may go back and say, this is a really interesting research question. It is missing the perspective of the consumer. So we're predisposed to look favorably at this proposal, but we need to see how this will actually engage consumers. That's flowing right up to the models of the Canadian Institutes of Health Research. So I think at the end of the day, the challenge, of course, is it not being route or not being window dressing, as Anne's mentioned, that it is real engagement where there is lived and learned opportunity. But if you embed the patient and their family in every step in the process, researchers are smart people. When they realize that for me to be successful, I really need to make sure that my question addresses the needs of the consumer. It's profound and profoundly shaping. But you know, while I say that, I also say we have to prevent the pendulum from swinging away from the very basic science, which we know is the underlying basis many years later of the advances in things like deletion syndrome. So, you know, it is, again, how do you create that balance of supporting the very laboratory-based, curiosity-driven question, which is incredibly important in every facet, right through to does this actually meet the needs of the consumer? And then last and certainly not least, are we retrospectively, and I'd love to hear from Sharon on this, we're all very good at saying at the outset, oh, here's who we've involved and here's what we've done and here's the good process. But do we look backwards and say 5 years later, how satisfied is Anne on this journey and her daughter? And oftentimes we're very good at laying the document on the table when we get funded, and we're not very good at going back and actually saying, let's do that retrospective evaluation and go back and talk to the community who was in this domain 5 years ago when we started this. Is it better? And if the answer isn't clearly yes, not sure we should be proud of our result.
Sharon, do we ever do this? Do you ever take the look back?
I'm not aware that we do. That might be another area of the NIHR. But I think we have a particular area of the NIHR that is involved with disseminating all the results that our evidence, or some of our evidence that we produce. But I'm not aware of anything that we do specifically that Kevin mentioned. But I'm not saying that we don't, but I'm just not aware of it.
Yeah.
Mairead, one of my, I suppose part of my vision would be that we would do longitudinal research through the clinic, and we would be consistently looking back, because it's looking back. It's all sorts of things on all sorts of levels, because you're looking back, but at the same time, you've got new families coming in, you've got new children, you've got teenagers. This transitionary period for our children is like minefield, because they also have learning disabilities. So, you know, it needs to be lifespan approach. I think well, in our situation, I know all research is different, but a lifespan approach. But you asked, Kevin, about how do you keep the balance? For me, it's relationships. It's as simple as that. It's building these simple, trusting relationships with everyone, with the researcher, with the clinicians, with the families, and I think that for me is the answer for me, like to that conundrum.
Absolutely, it's the basis for everything. The basis for everything that works.
Yeah.
I'm going to just finish up here, because there was a question that's come in, Andrew. Maybe I'll just give it to you, which is specifically around the example that you gave, and somebody was being very complimentary here about your whole systems approach. But the question was how you're going to ensure, this is with your initiatives that you're running in UHN, how are you going to ensure agility and sustainability over time, and how do you ensure that all the different interests and priorities are balanced? So, Andrew, would you like to comment on that? Just the sustainability of your initiatives?
Yeah, thank you, Dr. Driscoll, and thank you for the question and the comments, and I think, I'm just been so great to hear this conversation, be part of this panel about, the questions around, what matters, as Anne was saying. I was just reminded and sort of hoping to address this question on sustainability. I think part of it is defining, what is sustainable. I think we've always talked about sustainable spending, sustainable health spending. Well, sustainable for whom and for how? And how have we decided to define that question? I think there's been longstanding debate amongst health economists about even the question of sustainability and how much we should be spending. And I think we looked at some of the aspects of the presentation. I don't think that our spending in education and housing has been sustainable versus maybe the questions that we've always asked about, well, will our healthcare system be sustainable given the growth of the percentage of GDP? And I just think that is really reminded of that with Anne's great comment about, what being able to make a difference and what matters to people. And I think one of the flips about where I hope we see different voices to that point about ensuring that there's a different dynamic and about how we're ensuring that this continues is, I think that we've seen for a long time, a very paternalistic aspect in our system about prescribing or telling people what they need. And I think the question we've always been trained in medicine is sort of, what's the matter with you, to get symptoms. But a colleague of mine has reminded me that it should be more about, what matters to you. And I think that's what we're trying to do with the aspect around housing and this element of where we've been listening to communities that have long been calling for this. Again, this is, not new around the housing crisis. And again, when we think about pandemics, you can make the argument that the fact that people only live half as long, have a life expectancy in our country of 40 to 50 years old for people who are surviving homelessness, that has siphoned away so many life years and has really been, a pandemic in terms of its public health toll on people. And there's been, very, very notable, especially in Black and Indigenous communities that we've seen through the latest data in terms of how that has happened. So I think, in the latter part, we've got to ensure that there's a different approach in that co-design element, again, where there's the engagement and partnership up front about how this is being designed, as Kevin has spoke to. That is a notable difference than some of the other ways, and I think built on Anne's point, both from research, but how we're creating and lifting up this housing, again, hopefully in 2022 as phase one. And then I think on the sustainability piece, I do think to some of Kevin's points, what we've looked at from the data about our utilization. I mean, the question that I would flip and ask back, is it sustainable for us to continue running our health system the way it is, which was to ignore and neglect the housing crisis? And again, when you look at the data that we were able to pull and analyze in terms of people and postal codes, and as Kevin mentioned, people coming in more than once a day, not because in some of the instances that they were needing medical help, but because there was no other shelter, there was no other opportunities to get food, or to Anne's point about social isolation, to talk to anyone, to be able to get some care and be able to feel no longer invisible, which has been happening for too long. We still are having ways that we have to ensure that we're doing a better job of, improving our quality of care, embracing that in our emergency departments, but also looking for some of these more upstream solutions. So I think the sustainability piece, is if we can change some of the utilization aspects, but also improve the quality of care, and we think of the larger overall system spend, I think there's ways that we can continue to make that case. And again, that's part of the evaluation piece for this, as this is a more novel venture. And then I think really, again, it's got to be about every level of government ensuring this is happening, in terms of when you think about the structure is really important with both the city and the federal government, but really looking for provincial supports around the kind of supportive and social medicine nature of things that need to be there by the way of community health workers and ambassadors to be able to help people navigate not only some of their health challenges, but some of the social supports that are needed. And as we haven't seen those things happen before, our hope is that we could actually see, optimization for people's, health outcomes, their quality of life, their human dignity, and actually see a change in the way we're seeing some of the spend and utilization to something that's much more effective and equitable. But I think Kevin has some thoughts on that, and thank you for the question.
Yeah, right. I'd only add, the age-old scorecard, right? With Anne's comment about the partnerships, right? So what's the target, right? If last year we saw this many people who required a different approach to treatment, next year will we see a decline in those numbers? And to the question around the bureaucratization of these models, what are the targets of turnaround? So, for many years, people would languish in an emergency room because there was nowhere else to go. Really a terrible place to languish, frankly, and interrupt the flow for other medically ill patients who are trying to get in emergency rooms with ambulances virtually being told, I'm overwhelmed, I don't have any room, so go somewhere else. Well, there's nowhere else to go. So I actually think it is coming back to that scorecard of performance improvement, including time to disposition. So if you say, I was seen in an emergency room, and at the moment it takes me this many days or weeks or whatever to get the services I need. Next year, should there be a target? And again, I'm not suggesting that incentives solve all problems, but innovation usually requires investment. And where I think often funders get it wrong, could you please innovate, and could you please roll it out at the maximal efficiency that it could ever generate? And those are just antiquated concepts. You need an investment in innovation, and then that innovation hopefully reaps reward. So there is actually a payback. And by all means, we should be held accountable for that payback, and begin again with the various groups, as Anne's lined out, talk about what are those returns, and in what's a reasonable period of time to get there. And again, if we didn't get there, why not? Did we give it our best effort? Obviously there'd be a bunch of things during COVID that we all planned to do that simply didn't get done. I think most funders would be sympathetic to that, all funders, frankly. But if you're continuing to fund a program, whether that's through the HRB or another initiative, and you're not getting any results, it doesn't take that long for decision makers to have to say, is this the best investment, or do we need to revision this and put it into a different model? So I think it is expected performance results and markers of movement, both process markers and outcome markers. As we know in healthcare, it takes a long time to get outcome markers. Absolutely. But are we seeing improvement, and are we measuring it and demonstrating?
Thanks, Kevin. Excellent points indeed. I think this is a fascinating conversation, actually. We could go on for a long time, but I think we're probably running out of time, so we better wrap up at this stage. I want to thank all of our speakers, Anne, Sharon, Kevin, and Andrew, for sharing your perspectives, really, and all your kind of very diverse insights. I mean, it was very, very it was excellent and very thought-provoking to hear about your experiences. And I should really give special thanks to Kevin and Andrew for getting up so early in the morning over there to join us. Okay, for all of you out there, we're approaching the end of the event. And just before I wrap up, I hope these discussions have given you a better understanding of what this initiative aims to achieve. And above all, that it's really that hopefully it's inspired you to submit a question or some ideas to this kind of wider campaign that the government is running, and hopefully as well it's offered you some practical guidance on how to approach piecing your ideas together. Echoing what the Minister said earlier, I mean, think about the opportunities or challenges that maybe you've identified in your own life, or something you're maybe just curious about or concerned about, and send in your ideas or questions if you want to be part of it, the initiative, and help create a better future for everyone. And what's going to happen, I think, as Jennifer mentioned earlier, your ideas will contribute to an overall report that the campaign organisers will then submit to government in March next year. So this is a unique one-off opportunity. Think big, consider how we can tackle future health challenges, no matter what shape or form they take. But of course, it's only going to happen with your help. Now, just very finally, to get involved and submit your idea, you simply visit the campaign website. It's called www.creatingourfuture.ie, and you click the Submit Your Idea button on the homepage. So it's I think it's up there just to show you, and that's to just shape the future direction of research. And just remember that deadline for submitting your idea is the end of this month, it's the end of November, so don't miss out. So with that, I'd like to thank each and every one of you for coming together to make our event possible, for your questions, your curiosity, and we look forward to continuing on this journey and this important national conversation. So meanwhile, from everybody in here in the HRB, thank you very much and goodbye.